All right, sir. We will call the Health Subcommittee of the Health and Education Committee to order. And Mr. Clerk, can you call the roll?
Senator Saslow? Here. Senator Barker? Senator Dunavant? Senator Suderline? Senator Lewis?
Here.
Mr. Chair, we have a quorum.
Okay, that's great. So we'll just take these things in order. And it looks like the first bill I have up is House Bill 1831.
Thank you, Mr. Chairman. And members of the committee, House Bill, and excuse me for just 1 second here, let me get that back up. I'm in two committees at the same time here. House Bill 1831 is a bill that was brought to me by the Association for Home Care and Hospice. It very simply codifies existing practice. One is to allow the supervision of home care attendants that are providing personal care services to be performed by a licensed nurse rather than mandating it be a registered nurse. And the other is it allows for the use of supervision through audiovisual, basically allowing telehealth to move into the home care space for this as well, for the supervision purposes. Again, both of these things are existing practice today, and we just wanted to get this into code, and happy to answer any questions.
And Delegate Head, I noticed that it passed unanimously out of the House Committee and unanimously out of the House. And while that doesn't always ordain success over here, it appeared to have a great deal of support. So any questions for Delegate Head? All right, we operate on motion.
Move to report.
Senator Saslow seconds. It's been moved and seconded that House Bill 1831 be recommended for reporting. Clerk, can you call the roll?
Senator Saslow? Senator Barker?
Barker?
Senator Dunavant?
Yes.
Senator Suderline?
Yes.
Senator Lewis?
Yes, aye.
Ayes 4, no 0.
All right, thank you, Delegate Head.
Thank you, Mr. Chairman.
Next up, we have House Bill 1915, Delegate Ayala.
Thank you, Mr. Chairman, sorry. Delegate Ayala, and good afternoon, Mr. Chairman, and of course, members of the subcommittee. Mr. Chairman, 1950 requires the Virginia Department of Health and the Office of Medical Examiner to establish a work group to make a detailed plan to establish a fetal and infant mortality review team in Virginia. This work is necessary. Currently, Virginia ranks 21 in infant mortality rates as compared to other states. Black women are 9 times more likely than white women to lose their pregnancies in Virginia. Governor Northam announced his goal to address the maternal mortality disparities by 2025, but it's impossible to address the mortalities while ignoring the preventable fetal and infant deaths, since we don't know what the rates, since we know that the rates are mirrored. This mortality review team is essential to address these disparities. The Commonwealth will now join 28 states that have existing review operations for these cases as we implement the program. I hope it be the will of the body to join me in supporting this bill by passing it.
Thank you, Delegate. And I'd point out to the subcommittee that this one also passed unanimously through committee and the whole House, and so obviously a great deal of support and a very important issue. So any questions for Delegate Ayala?
Mr. Chairman?
Senator Suderline.
This seems like one of the most important work groups we could get going, so I'm going to move that we report, and Senator Dunavant seconds that recommendation.
All right, it's been moved.
Pardon me, Mr. Chair?
Yes.
We do have public comment.
I'm sorry. All right. Yeah. Let me say this. Is there anybody who wants to have public comment against the bill?
If those against the bill could please raise their hands digitally. And Mr. Chairman, we have one hand raised.
Oh my, okay. Go ahead then. Let the opposition speak first.
Olivia Turner, please unmute and begin.
Actually, I think there was a confusion. I am not speaking against the bill. I'm very
Oh,
pleased to be
that's-
speaking
that's-
for it, Senator. I'm very pleased because it's my friend Delegate Ayala, who
That-
served with
that's-
me on the Governor's Council for Women a few years ago, and this is an extremely important bill, and I appreciate Senator Suderline and Senator Donovan for stepping ahead on this. This is a very important thing for the women and children of Virginia. So thank you, Delegate. It's good to be working with you on something like this.
We were relieved to hear that there was a mix-up because we were anxious to see who was going to speak in opposition to the bill. So thank you very much. If everybody else on there could, this train is leaving the station under a full head of steam. So if you just want to identify yourself and that you support the bill, that's great. So.
Mr. Chairman, there are no other hands raised.
Is that it? Okay, great. So we've got a motion properly seconded that the bill be recommended for reporting. Mr. Clerk, will you call the roll?
Senator Saslaw. Senator Barker. Senator Donovan.
Yes, by proxy.
Senator Suderline.
Yes.
Senator Lewis.
Aye.
Ayes 5, no 0.
All right, Delegate, thank you.
Thank you. Have a wonderful day. Thanks.
Next up, we have House Bill 1963, Delegate Bagby.
Thank you, Mr. Chair, members of the committee. House Bill 1963 codifies the cooperative health budget and funding formula that has funded local health departments for decades. It sets the current minimum and maximum match rate for each locality of 18 and 45% respectively of the combined state and local contribution. Additionally, it requires the Virginia Department of Health to conduct a biennial reevaluation of the local match rates and report its findings and recommendations to the governor. I hope the committee acts favorably, and I suspect that there's no one here to speak in opposition, but Dr. Walker Harris should be present to answer any technical questions that you have.
All right, thanks, Delegate Bagby. Any questions first for Delegate Bagby directly?
Yes.
Senator Suderline.
Thank you, Mr. Chairman. So looking at this, it appears that there's an increase in the total funds, but there may be decreases to some jurisdictions. Is that correct?
That is correct. Some jurisdictions, after the hail harmless time frame, some jurisdictions might be impacted negatively. But as you can tell from the fact that you don't have them knocking down your door and here to speak in opposition, they know this process is fair. And even though the number may be going down for them, they feel confident in this process because it's something they've been codifying, and at least they know where they stand.
Mr. Chairman, one follow-up question.
Yes, Senator Suderline.
Just because I've got a proxy and I'm confident he knows the answer, what was the effect of this on Henrico?
I wouldn't be sitting here today if Henrico wasn't supportive.
That's what I trusted, but I did not want to hurt the good doctor. Thank you.
All right, thank you, Senator Suderline. Is there anybody signed up to speak in favor of the bill?
Mr. Chairman, there are no hands raised.
All right. Anybody else have any questions or any discussion on the bill?
This is, Mr. Chair,
Yep, Senator Barker.
this has been a many decades in waiting bill to come forward. I can recall sitting in education and health meetings back in the 1980s when Virginia Beach every year kept trying to get them to update the formula and update the allocations, and that never got passed until now. So,
Good. It's an important piece of legislation. Thank you, Delegate Bagby. We work by motion.
move to report.
Moved and seconded that we recommend House Bill 1963 for reporting. Mr. Clerk, will you call the roll?
Senator Saslaw. Senator Barker.
Aye.
Senator Donovan by proxy.
Yes, by proxy.
Senator Suderline.
Abstain.
Senator Lewis.
Aye.
Ayes 4, no 0, abstentions 1.
All right. Thank you, Delegate Bagby.
Thank you.
Next up, we have House Bill 1976, Delegate Willett.
Thank you, Mr. Chairman and members of the committee. HB 1976 is a bill I worked on in collaboration with the administration and then Dr. Megan Healy, who's the governor's chief workforce development advisor, helping to address the health workforce shortage. It's been an issue before the pandemic and has certainly gotten only worse during the pandemic. Very briefly, this bill will broaden the responsibilities of the Virginia Health Workforce Development Authority, giving them additional look into developing strategies to increase diversity in the healthcare workforce, for example. The bill also makes several strategic changes to the composition of the VHWDA board. And I should mention I serve on that board along with Senator Barker. And we hope this will help to address this workforce shortage. And I hope it also be the will of this committee to report this bill.
Thank you, Delegate Willett. Are there any questions from the committee for Delegate Willett? Is there anyone signed up to speak on House Bill 1976?
Yes, Mr. Chairman, we have one hand raised.
Okay, let's go forward.
Megan Healy, please unmute and begin.
Oh, Megan, okay.
Good afternoon, Chair, members of the committee. Just Megan Healy, Chief Workforce Advisor. Thanks for Delegate Willett for carrying this bill on behalf of the administration. Also, thanks to Senator Barker for your leadership as the chair of the Healthcare Workforce Authority. We've been working on this for this past year with the Virginia Hospital Healthcare Association. We had about a 30-member task force that came up with recommendations, and these recommendations came from that task force.
All right, great. Thank you very much. Any other questions for Dr. Healy or for Delegate Willett? All right, we work by motion.
Move to report.
It's been moved and seconded that House Bill 1976 be recommended for reporting. Mr. Clerk, call the roll.
Senator Saslow. Senator Barker.
Aye.
Senator Donovan by proxy. Senator Suderline. Senator Lewis.
Aye.
Ayes 5, no 0.
All right, there you go. Thank you, Delegate Willett.
Thank you, Mr. Chairman.
Next up, we have House Bill 1987 by Delegate Adams.
Thank you, Mr. Chairman, members of the committee. House Bill 1987 is similar to Senate Bill 1338, which passed this committee unanimously on 21st of January. It updates the state health plan to allow reimbursement for audio-only telehealth services and codifies prescribing via telemedicine. It also directs Medicaid to provide payment for, remote monitoring services for certain high-risk patients. I'm sorry, I was trying to vote in another, I apologize. Certain high-risk patients. Finally, it provides added flexibility that allows the Commonwealth to adapt to federal changes in the telemedicine policy. Telehealth is a key factor in ensuring that patients have access to necessary care, regardless of their ability or where they live. And this bill helps bring Virginia's telehealth plan closer to offering the full suite of services that patients require. Many of the payers, including Medicare, have used remote patient monitoring in recent years to enable chronically ill individuals and other patients to remain at home where they prefer to stay. And these programs lower the cost of care, reduce emergency department visits, hospitalizations, readmissions, and shorten length of stay in the hospital, all of which help improve quality of life and contain costs. This bill directs Medicaid to begin its own program for certain high-risk patients. In the past, telemedicine has been an increasingly common tool in the toolkit for healthcare providers, and the ongoing pandemic has accelerated the establishment of telemedicine as a key vector for providing critical care to patients. These changes serve to make telemedicine more accessible for patients and providers and lower the cost of care. And I thank you, Mr. Chair.
Delegate Adams, you mentioned which Senate bill is this similar to, and how does it differ from that Senate bill?
So the Senate bill is 1338, which is Senator Barker's bill. What it addresses that is different is the prescribing piece, and this adds flexibility such that we codify prescribing via telemedicine, and it basically it will allow for the expansion should and when the federal government expand telemedicine prescribing.
Thank you. Any questions for Delegate Adams?
Well, Mr. Chair, there's also another significant difference between the two bills. The bill that we passed in the Senate would go into effect presumably July 1, and there is money in the budget to fund the Senate budget to fund it. Delegate Adams' bill would not go into effect for another year after a year from July. and
Yes, sir, Mr. Chairman, that is correct. I apologize. We did not have the approval for funding the first year, and therefore it was establishing a protocol, and so the funding for, not the entire bill won't go into effect for a year, but just the remote health monitoring.
Senator Barker, would it be appropriate to recommend, and I can't remember how we do this at the subcommittee level, would it be appropriate
recommend conforming
Yeah.
the budget to the Senate bill
Yeah.
that was there.
So moved.
And we do have, 700 million reasons for being able to move forward on this.
That's right. All right, it's been moved, and Senator Sasslaw seconds that we recommend conforming House Bill 1987 to Senate Bill 1338 in reporting. Mr. Clerk, will you call the roll?
Senator Sasslaw? Senator Barker?
Aye.
Senator Donovan by proxy?
Yes, by proxy.
Senator Suderline?
Yes.
Senator Lewis?
Aye.
Ayes 5, no 0.
Thank you, Delegate Adams.
Thank you, Mr. Chair, members of the committee.
Next up, we have House Bill 2007 from His Excellency Delegate Sickles. Uh-oh.
Thank you, Mr. Chairman. I'm
There
just
he
turn my, can you hear me?
Yeah, we've got you. Go ahead.
Thank you, Mr. Chairman. 2007 is a bill that's trying to provide more drug price transparency for Virginians by way of an introduction. There are currently 10 states, are red states and blue states that have passed comprehensive prescription drug transparency laws. Over the summer, HWI convened the Health Professions Subcommittee educational series on prescription drugs to look at drug price transparency and to give stakeholders the opportunity to share insight into the process. Stakeholders included the wholesalers, generics, the supply chain folks, the pharmaceutical companies, and the PBMs. This bill before you is a result of those meetings after working with all the stakeholders to increase transparency in the prescription drug pricing process. It accomplishes the following: all participants in the drug supply chain must report information to the Department of Health annually, and the information is published on the Department's Health website, and it's with the assistance of the Virginia Health Information organization that exists now and is funded in the House budget. If a company does not report, the state can impose a civil penalty up to $2,500 a day. There's a lot of kind of dense text in this bill when you read it. I could go through that, but it requires things for, as I said earlier, pharmaceutical manufacturers, for the health insurance carriers, for the PBMs who are sometimes part of that health insurance carrier, and then the wholesale distributors. The bill will also require a health plan when they're offering a plan to fully insured customers, the option of extending point of sale rebates to patients. Rebates are an important part that make of the system that the pharmacy manufacturers like to sell their product, and also consumer advocates also like. I do think at times they tend to work against the objective of this bill, which is to get more transparency. If you price something at 5 times what it's worth and give you 4 times as much rebate, you feel really good about it. But I think as we slice and dice and go forward with this, the data, it will give us a better picture of what the situation is in our state. For instance, brand name drugs, this is some of the information that's required. If the drug costs $100 or more for a 30-day supply or a single course of treatment, any increase of 15% in the wholesale distribution price must be reported to the Department of Health. That's same as 4 other states require this, and it's stricter than 3 others. For the health carriers, they have to produce their 25 most frequently prescribed drugs, 25 with the greatest cost, 25 with the most year-over-year increases. And I could go on like that, but I think there are people that might want to, in the interest of time, testify to the bill that are waiting in the room, Mr. Chairman.
First, are there any questions for Delegate Sickles?
Mr. Chair.
Yeah, well, I meant from the committee members.
There is.
So Yeah, go ahead.
Sorry, I'm Anna Moore. I'm the
Right.
DLS. I just wanted to remind Delegate Sickles, did you want to do the amendment for this bill?
Yeah, when you started talking, that reminded me. And, there is a technical that I would ask the committee to adopt before we go forward, or not.
All right. You say it's a technical
Mr.
amendment,
Chairman.
Delegate Sickles?
Well, council could describe it if that's suitable, Mr. Chairman.
Yeah, that's fine.
Yes, sir, Mr. Chair. It's just on line 258, striking "and the Bureau of Insurance of the State Corporation Commission," and it's also posted on LIS.
Okay. All right. So we have a proffered line amendment. Does anybody want to make a motion on that? Moved and seconded that we adopt the amendment. All in favor? Aye.
Aye.
Opposed? All right. The amended bill is in front of us now. Any questions from the subcommittee for Delegate Sickles before we go to public comment? All right. Have we got folks lined up?
Yes, sir, Mr. Chairman. We have 6 speakers in the queue.
Okay. Well, let me just make a couple of observations before the speakers come on. This bill passed out of the House committees with only 1 dissenting vote and the entire 100-member House of Delegates with 1 dissenting vote. And it is the process of a long, drawn-out stakeholder process, from what I understand from Delegate Sickles. So having made those observations, let's start the public comment.
Jill Hankin, please go ahead.
Thank you, Mr. Chair, members of the subcommittee. I'm Jill Hankin from the Virginia Poverty Law Center. And I do support this bill because I think it is a very important first step to collecting important information about drug pricing in Virginia. The problem, however, in the bill is there is no first step to help consumers in any way deal with the exorbitant prices of prescriptions, of their prescriptions. And, you know, when people need to pay a coinsurance for drugs, if they need specialty drugs, those are quite exorbitant costs. So what the Virginia Poverty Law Center would like to see is that the bill timeframes be accelerated so that we can get started more quickly with the data collection, so there is a possibility we can get some real consumer relief and real consumer reform done or considered in the legislature of 2022. Right now, there's a delayed enactment clause until January of 2022. Systems just won't be in place quick enough so that we can get information and get the ball rolling. So we would suggest or ask you to consider amendments to delete the enactment clause delay and also change the reporting dates from April 1st to October 1st. That would be on 3 different lines of the bill, 369, 389, and 496. And then another method used by some other states to jumpstart the process is for the very first year of reporting that all the participants report three years of data instead of just 1. So that would give us a more complete picture from the get-go and allow the General Assembly to consider ways we could actually improve drug pricing for consumers. Thank you.
Right. Yes, ma'am. Thank you. Next.
Next, we have Scott Johnson.
Mr. Johnson.
Chairman Scott Johnson. I'm speaking on behalf of the Virginia Biotech Association. Our work with Delegate Sickles and the other folks that have been on this is to keep in mind the innovation in Virginia, not only for the small companies, but for the larger companies. And this bill, while not perfect, strikes a balance, and that's why we support it. I would draw your attention to the end of the bill and the comments of Mrs. Hankin. This bill is going to require emergency regulations the quickest we can move with for our state agencies to get this stood up. 280-day regs, as you're familiar with all the time. Those regs have to start and get in place after the bill becomes law in July. Hence, that was the reason for the delayed effective date of January 1, 2022, and the first report would then follow in April. So it has to be workable on the state side. It also has to be workable on the manufacturer side, those members of ours. So we would ask you to advance the bill in its current posture. Thank you.
All right. Thank you, Mr. Johnson. Next.
Doug Gray, please unmute and go ahead.
Mr. Chairman, thank you for the opportunity to speak on behalf of the Virginia Association of Health Plans. I wanted to commend the sponsor for bringing this legislation. We have supported legislation on drug transparency for the last 3 years, and we're happy to see that something is starting to move. We realize it's complicated and it's difficult, and it may need to be done in phases as this bill is, but it is an important first step, and I wanted to commend the sponsor for taking it and for taking on the task of trying to get all of these different parties to work together.
Thank you.
Thanks.
Next.
Becky Bowers Lanier.
Are you there?
Yes, I had to unmute myself.
Okay.
Good afternoon, Mr. Chairman, members of the committee. I'm here on behalf of those individuals and organizations that represent people with pre-existing chronic conditions. And just to make sure to emphasize what Jill said earlier in her remarks is that we, while we want data to be collected, we don't want us to forget that people do need relief for the cost of medications and greater transparency. While it is commendable and it's something that we all need to go after, remember that there are consumers who are waiting to have some relief to their medications. And I speak on behalf of the Hemophilia Association and the Foundation and the Breast Cancer Foundation. Thank you.
Next, we have Harry Gowanter.
Good afternoon, Mr. Chairman and subcommittee. My name is Dr. Harry Gowanter. I'm a pediatric rheumatologist in Richmond, and I'm able to speak. And Delegate Sickles is tired of hearing me speak, I'm sure. But as by myself, as I've been very involved with drug pricing issues for a number of years. But today I'm also able to speak on behalf of the Virginia Society of Rheumatology and the Virginia chapter of the Arthritis Foundation. We very much support the accelerated start of this bill. I understand Mr. Johnson's point about the regulations, but I think the point here is, what is the point, the idea of the bill? The bill is it to provide data, or is it for the General Assembly to be able to do something about it? And if the latter is the case, then we need to have data sooner rather than later. And the data is actually very available from manufacturers, from the PBMs, from the wholesalers, and from everybody else. I'm able to go online and see how much my drugs cost and how much I pay. Physicians receive quarterly reports from carriers and PBMs on how much they are spending or costing their patients. And so that data is available. And there are now actually, Delegate Sickles, 17 states that have passed transparency bills, with another 15 that are looking at them. The only one that has reporting so far is Texas, and they are the ones who asked for 3 years of previous data to kickstart the process. So while I think it is certainly a challenge for the state to be able to come up with its data reporting system, there are other models that they could use from any of these other 17 states to also kickstart the process from their side. Patients and everyone else need to be able to have reduced total costs, not just the rebates and not just the copays, but how much all their costs are. And having this data made public is a good start, but having the General Assembly being able to look at it and then be able to act on it in a more rapid fashion is even better. So we support the previous suggestions, and thank you very much for your time.
All right, yes, sir. Thank you. Is there anyone else?
Mr. Chairman, we have one final speaker,
Okay, go ahead.
Howard Estes.
Thank you, Mr. Chairman, members of the subcommittee. Howard Estes, representing the Virginia Pharmacists Association. We are delighted to see Delegate Sickles take the lead on looking at drug transparency in Virginia. We think this is a good first step towards developing a regulatory framework, reporting of data. As Dr. Gwanter had said and Ms. Henkin had said, we're anxious to get this going. So we would love to see a faster timeline and speedier data and more comprehensive data that's historical in nature, so we can really get our arms around this issue and see where we can help the citizenry with their drug prices. Thank you.
Yes, sir. Thank you. All right, that completes the public comment. Is there any discussion amongst the subcommittee members? All right, and we operate by motion.
Move to report or to recommend reporting.
Moved and seconded that we recommend reporting House Bill 2007. Mr. Clerk, will you call the roll?
Senator Saslow?
Dick?
Senator Barker?
Aye.
Senator Donovan by proxy?
Yes, by proxy.
Senator Suderline?
Yes.
Senator Lewis?
Aye.
Ayes 4, no 0.
All right. Recommend reporting. Thank you, Delegate Sickles.
Thank you very much. Y'all have a great afternoon.
Next up, we have House Bill 2061. Delegate Willett again.
Thank you, Mr. Chairman, members of the committee. HB 2061 requires all healthcare providers who administer vaccines to participate and report into what's called the Virginia Immunization Information System, or VIIS. The VIIS is currently operated by the Department of Health. It's with the goal of supporting patients and providers in making health decisions by providing reliable, easy-to-access information about a patient's immunization history. Under current law, participation in VIIS is optional for the providers. It's also important to note that any patient who wishes to can fill out a form to opt out of the VDH reporting. The goal here with this legislation is to avoid over or under immunization. Right now, if that information is not shared, for example, if a family moves from one area to another and the doctors don't have a record of it, they may ask those children to be vaccinated again when they've already been vaccinated earlier. So I hope it'll be the will of the committee to report this bill. Thank you.
All right. Thank you, Delegate Willett. Are there any questions from the subcommittee of Delegate Willett? Do we have any people signed up for public comment on this?
Mr. Chairman, we have 3 speakers in the queue.
All right, let's hear from the public comment. Let's hear the public comment then.
We'll start with Clark Barano.
Mr. Chairman, members of the committee, Clark Barano with the Medical Society of Virginia, and in the interest of time, just say we support the bill.
Michael Martin.
Good afternoon, Mr. Chair and members of the subcommittee. My name is Mike Martin. I'm the president of the Virginia chapter of the AAP. We strongly support House Bill 2061 and think it's a very important step in the infrastructure of public health. And I can't imagine a more important time than right now during COVID and vaccination efforts that we're having, that this is a bill we need. Thank you.
Yes, sir. Thank you. Next.
Mr. Chairman, we've had a couple additional hands raised. We have 3 left.
Okay.
Howard Estes, please go ahead.
Thank you, Mr. Chairman. Members of the subcommittee, Howard Estes representing the Virginia Pharmacists Association, and pharmacists across the state appreciate and value the VIIS and strongly support the bill. Thank you very much.
Yes, sir. Thank you. Next.
Jonathan Williams.
Mr. Chair, members of the committee, Jonathan Williams on behalf of the Virginia Academy of PAs, and we support the bill.
Okay, thank you. Next.
And Mr. Chairman, the final speaker is Joe Hilbert.
Yes, sir.
Mr. Chairman, Joe Hilbert with the Health Department. The administration strongly supports the bill. Thank you.
All right. Yes, sir. Thank you. All right. Are there any questions after the public comment or any discussion amongst the subcommittee? All right. Delegate Willett, are you there?
I am, Mr. Chairman.
So I noticed you got 19 no votes on the House floor. What was the genesis of, was it just an anti-vaccination type thing or what?
Mr. Chairman, I'd be afraid to characterize it without knowing exactly, but there was actually no one who spoke in opposition to the bill. I could certainly surmise that there could have something to do with it. But I will note again that a family who does not want to participate in the information being reported can do so. It would not be optional for the providers. Providers would be required to.
Right, but the actual people getting vaccinated can opt out. That's correct.
That's correct.
All right. Okay, folks, we operate on motion. Anybody?
Mr. Chair, I make a motion to recommend reporting.
All right, we have a motion. Do we have a second, Senator Sasslaw? We have a motion and second that we recommend reporting. Mr. Clerk, can you call, is somebody getting ready to say something? Mr. Clerk, can you call the roll?
Senator Sasslaw, Senator Barker,
Aye.
Senator Donovan by proxy,
Pass.
Senator Suderline,
No.
Senator Lewis.
Aye.
Ayes 3, noes 1.
All right. Bill is recommended reporting.
Thank you, Mr. Chairman.
Yep. Thank you, Delegate Willett. Okay, we're going to go back now just briefly to House Bill 1831, which passed the House, I think, unanimously, passed through the subcommittee unanimously. But unfortunately, I neglected to take public comment, and there were some folks who wanted to say something about 1831. So if they're still there, I apologize and would be glad to hear from you now, although as I just stated, that bill has quite a head of steam. So go ahead. Yeah.
Kimberly Beasy, please unmute and go ahead.
Good afternoon, Mr. Chairman. Kim Beasley with the Department of Health, Office of Licensure and Certification. The administration does oppose this bill and continue to have concerns. The bill basically lowers the level of supervision and provides permanent off-site supervision of unlicensed persons providing personal care to one of our most vulnerable populations. The bill would permit telephone-only supervision for the duration of a client's care. The home care attendant would potentially be the only eyes and ears on the client after the initial assessment that's performed by a registered nurse. Even the use of the video technology would deprive supervisors of the use of other senses, example, smell, and supervisors would be limited to seeing only what is within the camera's view. The bill would likely decrease client safety by eliminating requirement that all supervision be in person. In addition, from our data regarding home care organization complaints, over 58% of the substantiated complaints against home care organizations in 2020 and 25% of substantiated complaints in 2021 included lack of supervision. Our staff met with Delegate Head to propose 3 amendments for this bill. Number 1 was that the supervision continue to be performed by a registered nurse. Number 2 was that the remote supervision be limited to just the COVID-19 public health emergency. And number 3, that the remote supervision include video technology and not just telephonic. Delegate Head only accepted the last amendment, allowing video technology to be an option, but rejected the other 2 suggested amendments.
Let me ask you this. Did you advance these objections and arguments when the bill was working its way through the House of Delegates?
We did not have a position at that time from the administration. We weren't
because I mean that was to say that was a healthy vote to get in committee and then unanimously on the floor without any debate, obviously. Anyway, all right. Thank you. Anybody else? Who else has signed up?
Mr. Chairman, I see no other hands raised at this time.
Mr. Chair,
Senator Barker.
I am highly sensitive to the statements from the administration through the health department in terms of sort of dealing with these issues. My 98-year-old mother-in-law is in a continuing care retirement community and gets some services in a home in her apartment there. And let me tell you, it makes a big difference when there is supervision and when there is not there. So I think that there's legitimacy to the issues that have been identified, not only in terms of the perception that they have about these types of things, but also the complaints that have come forward as a result of those. So I think it's worth reconsidering whatever action we took on this, which I don't recall. So,
well, we recommended reporting unanimously. So,
well, I must have missed that vote then. So, because I wasn't.
Mr. Chair,
this is the first I've heard of any of this. So,
Mr. Chair, Senator Barker did not have a vote.
He didn't vote
on that particular bill.
Oh, George, you're off the hook. All right.
All right.
Okay then.
Mr. Chair. This delegate.
Are you back? There you go, Chris.
I am back, and I apologize. I thought we had this settled and done, and I am candidly not only dismayed and irritated by what you've just been given from Ms. Beasley, but it is the most blatantly misrepresenting statement I have ever heard in my decade in the General Assembly.
Tell us how you feel, Chris.
So just so you know, and I think that you will have, given a little bit of time, I have tried to recontact and hope that Marcy Tedderton from the Virginia Association of Home Care and Hospice will also be able to weigh in. I only heard the tail end of what was presented, and it was enough to send the hair on the back of my neck up. But all I can tell you is everything that is in this bill is current practice for non-skilled care. And what Ms. Beasley apparently does not understand, what the Office of Licensure and Certification apparently cannot get through their heads, is that there is a distinct difference between skilled care and non-skilled care. And when you're dealing with skilled care, there's a completely different set of regulations in place, a completely different set of supervision in place, a completely different set of circumstances in place that would dictate different levels of supervision. But when you're dealing with the provision of care that is only personal care, which is ADLs and IADLs, 73% of the agencies that are out there in the Commonwealth provide only that. Or provide that, and they operate on different levels of supervision. And again, I will reiterate, everything in this bill is existing practice. And for this agency to have remained silent all the way through, to have contacted my office and made a very lackluster offer and then doing that, and then not bothering to show up in any of the House committees after they had made those suggestions, and they said, well, okay, you're probably right. Then coming back in and hitting this now with a notification the day before it comes up in committee it is absolutely maddening to me that they would make these kinds of claims, again, because this is existing practice and has been for over a decade as far as the supervision is concerned. Right. So
Chris,
clearly I'm very angry about this, and I don't lose my temper in a committee meeting very often, and I certainly don't like calling anybody out, but it needs to be called out because this is absolutely abhorrent behavior.
That's okay, and it's partially my fault because I didn't. It had such a big head of steam. I didn't think it, and it looked anyway. But I will say this, just by observation and not being critical of the folks. If this is such a horrible piece of legislation, it took them 3 weeks to realize it because they said they didn't have any position at all while it was working its way through the House process.
And if Ms. Tedderton, Mr. Chairman, can get back into the room, I think she will be able to validate everything I said from the industry, not just me as the patron, but hearing from the industry as a whole. And I think you will hear her validate everything that I've just said.
Was she signed up to speak? Do you know?
She was, Mr. Chairman, and then when it passed out unanimously,
sure.
she left and we all signed off. I went back to the committee.
Well,
So
I'll tell you what I guess we have to do, if for no other reason out of courtesy to Senator Barker, is having voted on the prevailing side by which we recommended reporting House Bill, whatever it is, I move that we reconsider that vote. Okay? Yeah, Dick, give me a second over here when you get through with your sidebar, please.
Mr. Chairman,
Yeah.
there is another member of the public with their hand raised. I'm not sure if that's still continuing or not, but.
Dick, say second.
Senator Saslaw seconds.
Yeah, he seconded. I heard him. All right.
Senator Saslaw?
All right.
Aye. Senator Barker? Aye. Senator Donovan by proxy? Senator Suderline? Senator Lewis?
Aye.
Ayes 5, no 0. Reconsider.
Now, did you say somebody had come back into the room to speak?
Mr. Chairman, we do have one other hand raised.
All right, well, let's hear it.
Marcia Tedderton, please unmute and begin whenever you're ready.
Are you there?
Yeah, Mr. Chairman.
Yes, go ahead.
This is Marcy Tedderton. I'm with the Virginia Association for Home Care and Hospice. I want to thank you and the committee members for letting me speak to this bill. This has been, as Delegate Head indicated, we've been working with the department for over 15 years on this particular issue. And there was a memo that was issued 11 years ago that allowed for licensed nurses to supervise personal care aides or home care aides that are working in a certain component. I believe it's part 5 of the regulations, which Delegate Head alluded to. Those are agencies that only provide services, non-medical services that are not under any kind of medical care or medical direction. They're ADLs such as bathing, transferring, preparing meals, some light housekeeping, things of that nature. Typically, families hire these agencies to come in. These services are in lieu of assisted living care or nursing facility care. We have had the privilege for the past almost 12 months now to do a wide variety of telehealth services in home care and hospice in both the medically directed care and in the non-medically directed care. There have been no issues with using telehealth. In fact, the skilled care agencies have been doing telehealth care for many years now. And the issue with the allowing licensed nurses to provide this care, it's allowable under the practice standards of LPNs to do supervisory visits of personal care aides, home care aides, just like they do in nursing facilities. So we're not asking for anything that hasn't been done and been allowed pursuant to a letter that was issued by the director of the Office of Licensure and Certification 11 years ago. We have asked on a number of occasions that this be included in any regulatory updates over the past 11 years. That has failed to occur. We have failed to have any significant changes made to regulations over that period of time. They have just been stagnant for a variety of reasons. And we went to Delegate Head and asked him to move this issue forward since we've really embraced the use of telehealth. And we're using stretchers in home care, just like every other healthcare provider is using a stretcher to provide services these days. There is no harm here. There is no public safety or health issue that has been specifically identified by the Office of Licensure and Certification. And we have talked to Mrs. Beasley and others at the office, at the health department, and they indicated via an email that they still had some concerns, but they're unable to identify specifically what those concerns are at this time.
Okay. Thank you very much. Are there any questions from the subcommittee members? George? Senator Barker? No?
No, not right now, no.
Okay. All right, so we've got the bill back in front of us to reconsider. Is there a motion on the bill, 1831?
I second Senator Saslow's motion.
We have a motion and second that 1831 be recommended reporting. Mr. Clerk?
Senator Saslow? Senator Barker?
No.
Senator Donovan by proxy?
Yes, by proxy.
Senator Suderline?
Yes.
Senator Lewis?
Aye.
Ayes 4, noes 1.
Thank you again, Delegate Head. That was the...
Thank you very much, Mr. Chairman.
All right, let me get back to the docket here.
And Mr. Chairman, my apologies for losing my temper a little bit. I'll try to keep it under control for you the next time you see me.
That's quite all right. It's quite understandable. I appreciate it.
We'll hold you to that next time, sir.
All right, next up, I show Delegate Lopez with House Bill 2124.
Hello, Mr. Chairman, members of the subcommittee.
Hello. Go ahead. Yep.
May I testify? Mr. Chairman?
Yep, go ahead.
May I go ahead?
Yep, go ahead.
Thank you, Mr. Chairman, members of the committee. As COVID-19 continues to spread, it is imperative that we do everything in our power to ensure that every person in Virginia has access to adequate COVID testing, treatment, and vaccination. Virginia can't begin to fully recover from this pandemic unless we have ensured necessary and vital medical treatment for every single person who has the potential to catch it and spread it to others. Even as we work to control the pandemic, Virginia still has a gaping hole in its coverage of COVID medical care that has the potential to threaten the entire Commonwealth's recovery. Federal law requires that states provide emergency-only Medicaid services to any low-income individual who would financially qualify for Medicaid benefits, but otherwise does not qualify for the program, mainly due to their immigration status. This program provides emergency assistance to those with the most immediate medical needs who cannot afford insurance, like people involved in accidents, suffering from heart attacks, or undergoing labor. My bill, HB 2124, recognizes the urgency and the magnitude of the pandemic by expanding emergency Medicaid coverage to include all COVID-19 testing, treatment, and vaccinations. No person in the Commonwealth of Virginia should have to go untested, untreated, or unvaccinated during the most catastrophic pandemic in a century due to their inability to pay or their immigration status. Prohibiting individuals from accessing affordable COVID treatment will have dramatically negative consequences for our ability as a state to inoculate the entire population and thus keep us all safe. The disparate impact of the pandemic on Black, Brown, and immigrant communities is well established. Latinos, for instance, make up 9.4% of the population, but make up 31% of the COVID cases in the Commonwealth, many of whom are essential frontline workers who must leave the house to bring home a paycheck. If low-income individuals in those communities are not encouraged to get tested, treated, and vaccinated, every member of the community suffers due to community spread. The Medicaid emergency-only mechanism is in place to ensure access to this essential care for Virginians in need. At least 12 states have administratively declared this COVID-19 policy for their Medicaid programs. Virginia and DMAS needs to follow suit. Mr. Chairman, this legislation is urgently needed to keep our community safe and healthy and help us finally defeat this pandemic. I hope it's the will of the committee to report the bill.
Thank you, Delegate Lopez. Are there any questions from the subcommittee for Delegate Lopez? Questions? Do we have anybody signed up?
Mr. Chairman, we have...
Oh, I'm sorry, wait, Senator Barker.
Delegate Lopez, what is the projected fiscal impact of this and how much of that's general fund?
Right now, it is sort of it's movable, Senator Barker. What's happening is the assumption is that HRSA at the federal level will cover these costs because of how the programs are set up. However, out of I think, a abundance of caution, there is a range of in FY 2022 of 0 to 1.2 million in the general fund, and then in 2023 0 to 1.4 million that the administration or as a part of the FIS. But at the same time, I believe that HRSA will cover these costs, especially because what we've added is a line in the bill on the House side that says this will be in effect during the course of the emergency. And so I believe that should address some of the issues that were brought up in the FIS.
Mr. Chair, just
Yep.
a follow-up question.
Senator Barker.
Delegate Lopez, of the, I think it was 12 states that you referenced that have already implemented this, are they receiving 100% of the costs from HRSA at this point, or are they negotiating with that at this time?
I believe it depends on the state, but I would have to get back to you with a specific list, and I can do that fairly quickly, Senator Barker.
Okay, that'd be great. Thank you very much.
All right. We do have people signed up, I believe, for public comment. Let's start that.
Freddie Major, please start us off.
Freddie Mejia.
Thank you, Delegate Lopez, and thank you, Mr. Chair, for the opportunity to speak to the bill. My name is Freddie Mejia, and I'm a health policy analyst at the Commonwealth Institute. And I also co-lead the Healthcare for All Virginians Coalition. I'd just like to mention that the Virginia Health Catalyst, the Latina Institute for Reproductive Justice, Virginia, New Virginia Majority, the Virginia Coalition for Immigrant Rights, and the American Lung Associations are supporters of this bill. As Delegate Lopez mentioned, we certainly don't want anyone to avoid COVID treatment based on fear of costs. We feel that this program would be an important backup option in case HRSA funds become unavailable. This would also give patients and consumers more agency when dealing with COVID-related healthcare costs. If they are billed for COVID services at market price by a provider who does not apply for HRSA funds for whatever reason, the patient will have an option to apply for emergency Medicaid to get those costs covered. So we certainly feel like this is an important bill in order to make sure that everyone has access to coverage regardless of status. Thank you.
Thank you. Next.
Next, we have Jill Hankin.
Hello, Mr. Chairman and members of the subcommittee. Jill Hankin from the Virginia Poverty Law Center. I want to just echo the remarks of Delegate Lopez and Freddie Mejia. This bill will provide protection for immigrants who are low income, who meet financial requirements for Medicaid, but don't meet the immigration rules to get full coverage through Medicaid. It is a protection that will support individuals who are not receiving services through the HRSA program. That is basically an optional program for providers to use when they provide COVID-related services to uninsured patients. But we've seen that HRSA program used in very different ways throughout the Commonwealth, but our Medicaid program would provide a standard unified access to services for this very vulnerable population that's been hurt so much through COVID, with disparate impact on immigrant communities, really threatening everyone. We want to make sure that we take all actions we can to ensure access to COVID-related testing, treatment, and vaccines. Thank you very much.
Yes, ma'am. Thank you. Next.
The last speaker in the queue is Yeli Montano.
Hi, good afternoon, Mr. Chairman and members of the committee. My name is Yeli Montana and I'm with GASA Virginia. On behalf of GASA and our members, we strongly support the passage of this bill and would like to thank Delegate Lopez and other advocates for bringing this bill along. The patrons summarized the bill very well, hitting on all the key reasons as well as the speakers before me. So out of respect of time, I would just like to add that we believe this bill will help us mitigate rising health disparities that we should expect to see post-pandemic time, support the most affected by the pandemic, and help us in our efforts to combat the pandemic, while also ensuring we vaccinate a sufficient percentage of the population in an equitable manner. Unfortunately, we're already seeing some of these members fall behind in vaccine distribution efforts. So with that, thank you so much for the opportunity to speak today.
Yes, thank you very much. All right, that completes the public comment, I believe. Are there any questions or discussion from the subcommittee?
Yes, just one further one.
Senator Barker.
Yes, thank you, Mr. Chair. As I read the bill, the public health emergency period during which this would be in place is a public health emergency declared by the U.S. Secretary of Health and Human Services rather than anyone in Virginia. Is that correct?
I believe it was, yes, I believe that's correct, Mr. Chairman. Let me just verify, make sure my assumption is correct. It's 42 USC 1396B, yeah. Yes, sir. Declared by the U.S. Secretary of Health and Human Services.
All right.
Yeah, Mr. Chair, I think the fact that it's tied to the state of emergency that has been declared by the U.S. government, that should help as it relates, and the Secretary of Health and Human Services being the person who did it, that should help in terms of getting the full reimbursement for the cost of these things. So I think that's a good sign.
Okay, great. Anybody else for Delegate Lopez? All right, we operate on motion.
Move to report or recommend reporting.
Senator Sasslaw, do you want to second that? It's been moved and seconded that House Bill 2124 be recommended for recording. Mr. Clerk.
Senator Sasslaw? Senator Barker?
Aye.
Senator Donovan by proxy? Senator Suderline?
No.
Senator Lewis?
Aye.
Ayes 3, noes 1.
All right, recommended reporting. Thank you, Delegate Lopez.
Thank you, Mr. Chairman, members of the committee.
Next up, we have House Bill 2154, Delegate Adams.
Good afternoon, Mr. Chairman.
Sir.
Thank you for hearing this bill and members of the committee. This is House Bill 2154. I introduced this bill following the experience of a constituent who was denied access to their family through virtual personal assistant and like an Amazon Echo, that sort of thing. And what we learned in the process of that experience was that there's a need for hospitals, nursing homes, and nursing facilities to implement policies that would allow patients the ability and to know what the parameters are for them to use this particular type of technology. So the bill that is before you that is passed out of the House, and by the way, it did pass with bipartisan support, not just with the final vote, but as you can see from the list of co-patrons, many of which are served on the Health, Welfare, and Institutions Committee, there was a recognition that this is a need. And I will say that we implemented language that was approved by the Virginia Department of Health. And I believe the bill has the endorsement still of hospital associations and nursing home associations.
All right, great. Thank you, Delegate Adams. Are there any questions from the subcommittee for Delegate Adams? Do we have folks signed up for public comment?
Mr. Chairman, we have one speaker,
All right.
Scott Johnson.
Scott, okay. Mr. Johnson.
Good afternoon, Mr. Chairman. Again, on behalf of the Virginia Healthcare Association, appreciate Delegate Adams working with us to address our concerns, and the bill in its current form has our support. Thank you.
Well, thank you, Mr. Johnson. All right, it's a pretty straightforward bill, passed unanimously through the committee process on the House side and passed unanimously on the House floor. And you've heard Delegate Adams' explanation. And do we have a motion?
Second.
Moved and seconded that House Bill 2154 be recommended for reporting. Mr. Clerk.
Senator Sasslaw? Senator Barker?
Aye.
Senator Donovan by proxy?
Yes, by proxy.
Senator Suderline?
Yes.
Senator Lewis?
Aye.
Ayes 5, no 0.
All right, thank you, Delegate Adams.
Thank you, Mr. Chairman, members.
All right, next up we have House Bill 2162, Delegate Tran.
Hello, Mr. Chair.
Hello.
Okay, good. I'm so glad. Thank you so much for the opportunity to present House Bill 2162. This bill provides a right for individuals with disabilities to have a designated support person accompanying them to hospital visits and stays if they to provide assistance with things such as communication or daily living activities, such as toileting and eating. We know that this type of support provides really positive patient outcomes, and it also helps to alleviate some of the strain on the medical professionals who are at the hospitals providing care for other patients. This issue was brought to me by several constituents, and since then I've heard from numerous families across Virginia who have directly experienced difficulty being such a designated support person for their family members when they are having hospital stays. And so I welcome your questions, and we have a number of supporters for this bill. And let me just list them out very quickly in case they don't all get a chance to testify, but so you know the broad coalition of folks who do support the bill. So it's Virginia, the Virginia Autism Project, the Independent Center of Northern Virginia, the Alzheimer's Association, the Disability Law Center of Virginia, the Autism Society for Central Virginia, the Virginia Network of Private Providers, the Brain Injury Association of Virginia, and the National Alliance on Mental Illness of Virginia, and Autism Speaks. Oftentimes, the support that these individuals are able to provide for somebody with a disability can help clarify things in discussions with the medical professionals, and can also be life-saving in certain situations as well. I welcome your conversation today.
All right, thank you, Delegate Tran. Are there any questions from the subcommittee for Delegate Tran? So Delegate Tran, do I understand, so if someone qualified as a person with a disability under your legislation and they had to go into the hospital and check in for a procedure and spend a night, 2 nights, 3 nights, so this person would accompany them, and how does that work?
Yes, sir. They would be able to identify somebody who could accompany them. So in that instance, if they had to stay overnight, they would have somebody who could be sitting with them in that room, who could help them, go to the bathroom, who could help them with any communication issues that they may have. And I think any one of our witnesses today could also testify to their personal experiences in providing that care and what that meant for the overall medical care and outcomes for their loved person.
Okay. All right.
Yes, that's exactly what it would mean.
So we have I'm sorry, go ahead.
We did work with VHHA to make sure that we allow the right amount of guardrails. So, for example, a designated support person is not going to accompany their person into the surgery room, for example, and then or other areas where people can't go. And so there are guardrails that are in place working with VHHA to make sure that the hospitals are also comfortable in having this a designated support person on site as well. And I think in some areas right now in my conversations with VHHA, I understand that this has been for some hospitals a current practice or part of the culture, but we wanted to make sure that it was a right for every single individual with a disability in Virginia.
Okay, thank you. So we have public comment. How many folks do we have signed up?
Mr. Chairman, we have 4 people in the queue.
Okay. All right, let's try and keep it to, the night's getting long. Let's try and keep it to a minute if we can. I won't be too strict about that, but just to give folks in queue for public comment, we're going to try and keep your remarks to about a minute, okay? All right, let's start off.
Teresa Champion.
Thank you, Mr. Chairman, members of the committee, and I'd like to thank Delegate Tran for this particular piece of legislation. First, I'd like to read Tommy Elder's statement. He's not able to be here today. He's an individual who's a self-advocate. I was hospitalized for 45 days. My mom fought to be by my side. I'm here today as a doctor told my mom, you being here with Tommy to be his voice literally saved us his life. Please pass HB 2162. It truly is a life-saving bill for people like me. And I'll be brief. I'm with the Virginia Autism Project. My son has been hospitalized multiple times, actually 12 times between 2012 and 2015. And this was, of course, before COVID. One time I was not allowed to be there. He was placed in a cinder block room in the psych ward where he banged his head so severely he was bloody. One time I was there, he was given a chocolate peanut butter muffin. Now he has a anaphylactic reaction to peanuts. So it's important that people are there to assist with someone who can't communicate. He would have eaten that muffin and he would have died because he would have not been able to push the button and call for help. Thank you so much to Delegate Tran for this legislation, and we appreciate your time today.
Thank you. Next up.
Terry Morgan.
Ms. Morgan.
Hello, Mr. Chair and members of the committee. My name is Terry Morgan. I'm the Executive Director of the Virginia Board for People with Disabilities, and the board supports this bill as it reinforces patients with disabilities rights under the Americans with Disabilities Act, Section 504 of the Rehabilitation Act, and Section 1557 of the Affordable Care Act to DSPs as reasonable modifications and accommodations to equal access to treatment. The board supports this bill's notice requirements, which will help inform patients with disabilities of their rights to a DSP, and we thank Delegate Tran for carrying this bill.
Yes, ma'am. Thank you. Next.
Jenny Shatine.
Hi, good afternoon, Chairman and committee members. My name is Jenny Skatine. I'm with the Disability Law Center of Virginia. We are Virginia's protection advocacy system for individuals with disabilities across the Commonwealth. We support the bill as it enables Virginians with disabilities to receive the appropriate medical care and supports, both during the pandemic and beyond the pandemic. And we're grateful to Delegate Tran for bringing such important legislation. Thank you for the opportunity to speak.
Yes, ma'am. Thank you. Next.
Mr. Chairman, we have two speakers left. Tanya Milling.
Hi, Tanya Milling, Executive Director at the ARC of Virginia. I'll just echo the previous comments. We very much support this bill. Thank you so much.
Next.
Lastly, we have Brent Rawlings.
Mr. Chair, members of the committee, Brent Rawlings, Virginia Hospital and Healthcare Association. Delegate Tran did reference our involvement earlier. I just want to thank her for working with us to get the language on this and urge her support for the measure. Thank you.
Okay, great. Is that it for public comment?
Mr. Chairman, we have one new hand raised if you would like to hear from them.
Oh, yeah, sure.
Elizabeth Kumar, please unmute and go ahead.
Thank you. I'm Elizabeth Kumar. I'm from the Independent Center of Northern Virginia and a self-advocate. I'm very grateful to have this opportunity to speak with you today. As a person with multiple disabilities, including spinal cord injury, I feel it's important to have the right to choose my caregiver or support person if I was hospitalized during COVID. This is one of my many fears currently. It's important for this caregiver be permitted to be with me starting with admission and throughout the treatment process. They can provide vital information that can impact the decisions and outcomes related to my treatment. Thank you so much for letting me speak.
Yes, ma'am. Thank you. All right. Are there any questions or discussion amongst the subcommittee members? All right. The bill's in front of us. Is there a motion on the bill? Been moved and seconded that we recommend reporting House Bill 2162. Mr. Clerk.
Senator Saslow? Senator Barker?
Aye.
Senator Donovan? Senator Suderline?
Yes.
Senator Lewis?
Aye.
Ayes 5, no 0.
All right. Thank you, Delegate Tran. And finally, we have House Bill 2300 from Delegate Delaney.
Good afternoon, Mr. Chairman and committee. I do have House Bill 2300, and to begin with, we do have a quick line amendment that we need to offer that simply adds the Department of Health Professions, the lead agency on the work group, adds the Virginia Pharmacists Association as a stakeholder for the work group. Okay. These were amendments that were suggested by the Virginia Department of Health.
All right, Senator Barker moves adoption of the amendments, and Senator Saslow seconds. And all in favor? Aye. The amendments are adopted. So we have the amended bill in front of us, 2300. Go ahead, Delegate Delaney.
Thank you, Mr. Chairman. The bill before you is an amendment to Danny's Law, which passed last session and was carried by Senator Vogel. This bill requires hospitals and emergency departments to establish protocols for patients being discharged after a substance use related emergency. These protocols will include completing a substance use disorder assessment or screening, providing recommendations for follow-up behavioral care as appropriate, and referrals to peer recovery specialists and community-based behavioral health services. The bill also says that these protocols may include dispensing of an opioid antagonist or a prescription for that medication. I will just take a moment to note that the original version of this bill had that as a shall. We do think that ultimately that is where we need to get, where we have some of those requirements that did draw some concern for the bill. So we did, in interest of moving this legislation forward and moving the needle, change that to a may in the House. And that is, the intent to stay with that. But I did want to make note that I think we hope to be better informed on ways to move this issue continually forward. And that leads me to the final piece of this bill that requires the Department of Health Professions and the Virginia Department of Health to convene a work group to develop some best practices and a process in emergency departments or hospitals for treating and discharging patients experiencing an opioid-related emergency. Finally, the bill does allow hospitals to enter into a contract with VDH or other appropriate state agencies to provide opioid antagonists to uninsured patients.
All right, great. Thank you. Are there any questions for Delegate Delaney? Do we have anyone signed up for public comment?
Mr. Chairman, we have a rather large number of hands raised.
Oh, my.
Mr. Chair, I can note we do, I know, have a variety of people to speak. I can in the interest of time note that we do have a long list of support: the Chris Outwood Foundation, the Recovery Connection, National Alliance of Model State Drug Laws, Virginia Association of Addiction Counselors, NAMI Northern Virginia, Students for Sensible Drug Control Policy, Virginia Recovery Coalition, Virginia Harm Reduction Coalition, the McShin Foundation, Recovery Advocacy Project, SAARA, and the Levinson Foundation. I do know that there were a variety of speakers who did sign up. I do have a note that Dr. Turplin was here to speak and may have needed to speak first. So if the chair wishes to choose how to proceed, I'll just note that.
Can we pick Dr. Turplin out from the crowd and pull him to the front?
Yes, I'm here.
Hi. Comment. Yeah, go ahead, Dr. Turplin.
Okay, thank you. Thank you, Chairman. Thank you, committee. Thank you, everyone, for bringing this bill to the table. I'm an addiction medicine physician. I used to be on faculty at VCU. I still serve for DMAS as their addiction medicine specialist, but I'm not speaking with my DMAS hat on. Very briefly, I think everyone is well aware of just the ongoing and worsening of the opioid crisis, in particular through the last period of the pandemic. And frankly, the hospital response has been insufficient. I had a patient the other day who presented for care in withdrawal, who was not treated in an emergency department, who left against medical advice because of the quality of care she received, and nobody addressed her withdrawal, and nobody offered her naloxone. This is 2021. It's 10 years since the opioid crisis was labeled as a crisis. I strongly support any measure, to improve identification of people at risk of an overdose in order to, prevent people from dying. It's really that simple. Thank you.
Yes, sir. Thank you. Approximately how many people do we have signed up?
Mr. Chairman, there are 8 remaining names on the list.
All righty. Okay. Well, let's start. It would be helpful if if those folks kept their remarks. I think the bill is in good shape insofar as getting out of the subcommittee and going to the full committee. But if you would just like to state your name and your organization and your support, or if you think you have absolutely something vital to say that would inform our decision on the bill, you can go ahead and say that. But otherwise, let's try and move along. So let's get started.
Jenny Lovett.
Good evening. Thank you, members of the committee.
If anyone hasn't already heard this startling statistic, I just wanted to share with you all that drug overdose is the #1 cause of death in Virginians under age 50. And that was the case in 2018. But since 2018, those already high numbers have doubled. Unfortunately, my little brother Christopher was one of those statistics. He passed away from a heroin overdose at the age of 21. And he was treated in a Northern Virginia hospital for a non-fatal overdose just a few weeks before his death. And he was discharged with no resources, referrals, and most importantly, no naloxone. So when I came home just a few weeks later and found him face down on his bed, not breathing, there was nothing I could do to save him because I didn't have naloxone, because I didn't know how to get it. It hadn't been given to me. I was 25 years old. We were a family in crisis. We had no idea what to do, and the medical system failed us. So naloxone needs to be given to people like us in crisis, because unfortunately for many individuals like my brother, who have been lucky to just barely survive an overdose, we may have only one opportunity to get naloxone to them before they suffer another overdose. And studies show that 60% of individuals who have overdosed once will overdose again. So this is our chance to finally make real progress in the opioid crisis. And unfortunately, right now, the language of HB 2300 does not require any real change in the system that failed my family. So I would ask that you change the word may on line 203 into the word shall, so that hospitals are required to, at a bare minimum, let people know that they can get naloxone without a prescription under the standing order. That could have meant the difference for my family. And what we need really, truly, is to mandate that naloxone is provided to people directly, but it doesn't appear that the assembly is ready to take that step. So at the very least, if we change that one word, it would require hospitals to pick from one of three options. They could either dispense naloxone, prescribe naloxone, or just simply inform the patient about the statewide standing order and where they can get naloxone in the community. This is not codifying standard of care. This is simply providing information as a public service. So this is the least we can do for families like mine who are at risk of losing a loved one. And I would like to quickly, and I'm almost done, I promise, remind the committee that in 2017, or since 2017, Virginia has actually required doctors to prescribe naloxone along with opioid prescriptions. So what this means is that right now, we require naloxone access for people who are at risk of an overdose, but we don't require it for people who just overdosed and are in the hospital. This just does not make sense. Everyone says they want to take action against the overdose crisis, but few are actually taking meaningful action to do that. So please, I implore the committee to find it in their hearts to change may to shall on line 203, because even though this is just one small word for the committee, to Virginians with addiction, it could change their entire life, and it could have changed mine. Thank you.
Yes, ma'am. Thank you. Next.
Amy Siebert.
Yes, good evening, Mr. Chairman, members of the committee. Amy Parent-Seibert on behalf of the Virginia College of Emergency Physicians. And in the interest of time, I'll actually speak for my colleagues, which I think will take about three of these folks off the list, which is Scott Johnson, who's here for the Medical Society, Mark Hickman, who's here for the Society of Hospital Pharmacists, and Brent Rawlings, who's here for the Virginia Hospital Association. On behalf of all my colleagues, we appreciate Delegate Delaney working with us on this bill. We all do think this is a really important issue. We understand what the advocates are talking about. We just appreciate that this bill is permissive, and we look forward to the working group that's going to be happening, because we think it's really important to work through all the barriers and logistics that we have currently in Virginia on being able to give out naloxone in the ER. We typically do not dispense any prescriptions, any drugs in the ER. We only provide prescriptions, and that is something that happens actually around the country. And we're looking forward to looking at best practices and being able to move forward. Thank you.
Thank you. Next up.
Matthew Cobb.
Mr. Chairman, Matt Cobb with Williams Mullen, and I represent Emergent Biosolutions. We certainly prefer the original version of the bill that used the word shall rather than may with regard to the options available to the emergency department, but understood why it was changed in the House. I do really want to address a concern raised in the House that if shall is used in the bill legislates the standard of care. That is simply not the case. Under shall, or now with may, if a health care provider determines that it's not appropriate to dispense naloxone or prescribe naloxone, then all the ED would have been required to do was inform the patient of the standing order and their ability to access naloxone without a prescription at a pharmacy or community organization. Having said that, we do support this bill. Thank you, Mr. Chairman.
Yes, sir. Thank you. Next,
Nathan Mitchell.
Mr. Mitchell.
Thank you, Mr. Chair, members of the committee. I can only echo what Ginny Atwood Lovett has already said and tell you that I'm a person in recovery from a substance use disorder. I work with the McShin Recovery Resource Foundation and the Virginia Recovery Advocacy Project, representing several recovery community organizations here in Virginia and thousands of individuals across the Commonwealth. Please change that may to shall. Thank you.
Next.
And Mr. Chairman, since Ms. Siebert spoke for some others, the last speaker is Julie Funkhauser.
Yes, ma'am. Go ahead.
Thank you, Mr. Chairman, members of the subcommittee. My name is Julie Funkhauser. I'm the co-founder and CEO of the Recovery Connection, and I am also the widow to Danny Funkhauser, who died of an overdose on 9/11/2018, hours after leaving the emergency room in a drug-related psychiatric emergency where he was engaged very little and he was left without guidance or resources. He could still be here today raising our children with me had he been engaged and given naloxone upon discharge. The thing is, Mr. Chairman, police and EMT are not the first responders to substance use related emergencies and overdoses. Active users and those in recovery are the first responders. As the research tells us, we need to reach these folks and get this life-saving medication directly into their hands. They are the ones that are saving one another. Being in the industry and also a person in long-term recovery myself from opiate use disorder, I can honestly share with you that upon receiving naloxone, you go into acute withdrawal. The last thing your brain's telling you is to leave to go find or obtain naloxone at a pharmacy or elsewhere. Your brain is demanding more drugs. To save lives from this awful epidemic, we have a chance right now to reach the most vulnerable and those at highest risk. I ask that you please support the unamended language of HB 2300. Thank you so much.
All right. Yes, ma'am. Thank you. And does that complete the public comment?
Yes, sir.
Are there any questions or discussion amongst the subcommittee on House Bill 2300? All right. We've been moved and seconded that 2300 be recommended to be reported. All those, Mr. Clerk, can you call the roll?
Senator Saslow? Senator Barker?
Aye.
Senator Donovan? Senator Suderline? Senator Lewis?
Aye.
Ayes 5, no 0.
Thank you, Delegate Delaney.
Thank you, Mr. Chairman. Thank you, committee.
With that, folks, I believe that completes our docket for this afternoon, and we are adjourned.